to start the webinar. I think I'm in it. I think I'm starting it.
Okay, we're starting to see some attendees, so we are.
Okay, yeah, it would look like that I'm logged in as the host now.
Yeah, we have people are joining in now.
All right, very good. So we're logged in now, so it's got to be me.
All right, no problem.
Let's make this big and see if we can start to see.
Yeah,
We start to see attendees here.
yeah, you have 18 participants now. It's going up.
Yeah, it looks like I have 20.
Brian said he had 60 RSVPs, so
Yeah, we have 60 RSVPs.
We have 5 panelists and 18 attendees is what I see.
yeah.
We're just going to give them a couple minutes here since it looks like I had to be the one to open.
Oh, okay.
There must be some sort of block.
Sorry,
There must be some sort of block that it wouldn't let me.
because you're on my Wi-Fi, right? Okay. You want to just run it from here? That's going to be our safest bet.
Yeah, we'll have to.
Okay. So what I can't see, okay, here we go. So I'm seeing attendees now. I'm up to 24. I gotta mute your speakers.
Yeah, they're still coming.
They're still coming in here. Wow, we have a great, I'm seeing a great response here. We've got a lot of interventionalists here, some general, some invasive non-interventionalists, several surgeons from across the city. Okay, I think I'm gonna go ahead and start the meeting now. Obviously, you're aware of how to do this. You'll have to share your screen and such.
Yep.
So, well, good evening, everybody, and thank you for joining us for the SAFE meeting. This is another Zoom meeting, and Dr. Cohen has been graciously to provide us an hour of his time or a little more to talk to us about a subject that we haven't talked about a lot, and that's really kind of the economic aspects of structural heart programs, as well as then take a couple cases regarding difficult TAVR cases in our city and questions regarding that. Dr. Cohen is very well renowned in both economics as well as outcome research. He's an interventional cardiologist, currently at St. Francis Hospital in Roslyn, New York, with the Cardiovascular Research Foundation. Previously was professor of medicine at Missouri, Kansas City, director of cardiovascular research at St. Luke's Mid-America Heart Institute, and prior to that, director of interventional cardiology, director of cardiovascular research at the Beth Israel and Deaconess in Boston. Also associate professor of medicine at Harvard Medical School. He earned his medical degree at Harvard Medical School, master's in health policy at Harvard Public Health, and has completed clinical training at the Brigham and Women's, as well as clinical research fellow in cardiology at the Beth Israel. He's board certified in medicine, cardiology, and interventional cardiology. But really the reason we've asked him to come down, he's one of the guys who's actually done research in what we do and what's the economic impact of that, and are we doing the right thing for the patient? And graciously, with his relationship with Dr. Alamani, he's giving us our time. With that, I'm going to turn this over to you.
So you have to first let me share my screen. It's not letting me share my screen.
Okay. Mute. So make host.
I don't know. Let's see.
I'm going to make you a co-host. Let's see if that works.
All right. Yeah, it works. Yep. Can you see my screen?
Yep, we're good to go.
Okay. Let me make myself smaller so I can see my screen. Okay, great. Well, thank you very much for the invitation and for welcoming me into your homes for this evening. I'm going to give hopefully about a half hour or slightly less talk on the topic of cost effectiveness of TAVR in 2021, really focusing on some of the insights we've gained from the pivotal trials. And then I'll be really looking forward to going over some cases with you. These are my disclosures, and importantly, I get research grant support from a number of cardiovascular device companies, including a couple of companies that make transcatheter heart valves. So maybe I don't need to really start back to the basics, but why should we care about the economics of transcatheter valve replacement. Well, first of all, when we first started doing TAVR in 2008, for us, we were just treating the inoperable patients. And what we realized at that point is that TAVR leads to very substantial improvements in survival, and the benefits are sustained through 5 years. But there were already questions when we first started treating those patients. Is this, really a good use of society's money to treat these very old, very sick, very challenging patients? And that was really the question in 2007, 2008, 2009, 2010, is can we really afford to offer TAVR to all of these sorts of these extremely ill and complex patients? For the operable patients, the equation and the question really is somewhat different. So we know that for the operable patients, whether they're high risk or intermediate risk, there really is no difference in long-term survival with TAVR compared to surgical AVR, perhaps some very small differences in the early timeframes. In some complications we recognize are actually increased, like pacemakers and paravalvular aortic regurgitation. And obviously the TAVR prosthesis is much more costly. Even today, most of us pay around $30,000 for a TAVR valve and about $5,000 for a surgical valve. And so the question when we're comparing against surgery is whether there's an economic or a quality of life benefit of TAVR that can justify the more costly procedure. And finally, for all patients, I think a lot of us who practice in different places around the country recognize that there are substantial differences in reimbursement by geography. And in much of the United States, unlike on the coasts, the margins for TAVR are relatively limited or even non-existent. And with proliferation of programs, which last I checked is getting close to 750 in the United States, the early concept of a halo effect really doesn't exist anymore for TAVR, at least. And so most programs really need to find ways to maintain these margins in order to afford the add-on technologies, things like embolic protection, novel vascular closure devices, other sorts of challenging procedures. So I want to then kind of just take a step back and kind of bring you along the journey that we've been taking for the last decade with TAVR, and some of the key insights that we've gotten. We've been doing economic evaluations of technology for about the last 25 years. I started out evaluating stents. In the early 2000s, we started evaluating drug-eluting stents when they came along. And the third major technological advance that I've been privileged to study, both clinically and economically, is TAVR. And what we've learned over the last decade is that the cost effectiveness of TAVR is really dependent on the patient population, the alternative treatment options, and the access site. So let's go back in time, go back to 2009, 2010, to the original Partner B trial. Remember, this is the trial that really established TAVR in our armamentarium. This was the inoperable trial with 358 patients, all of whom were suitable for transfemoral access. We were then randomized one-to-one to either transcatheter aortic valve replacement or standard medical therapy, with a primary endpoint of all-cause mortality compared for superiority. And we were, again, very lucky to have the ability to collect data as part of the partner trial to assess for the first time the cost effectiveness of TAVR. And the first step we had to do was to figure out what it actually cost to get a TAVR. And in 2008, 2009, 2010, it was very expensive, especially for these inoperable patients, being managed with older generation devices. So the procedure itself, back at that time, cost about $42,000. The vast majority of that was the valve. The length of stay was about 10 days on average for these patients. Think about that in the current context, which added another $30,000 to the cost. And then the physician, the interventional cardiologist, the cardiac surgeon, the anesthesiologists, remember all of these procedures were done under general anesthesia back then. The total cost to get in the door and out the door from your TAVR in the extreme risk population in the Partner B trial was $78,000. So a pretty high price tag. So that was, if you will, the bad news. The good news is there were a lot of cost offsets. So over the next year of follow-up, there was a marked reduction in the number of hospitalizations in the patients who got TAVR. And you can see there were about $26,000 worth of cost savings there. There really were not any major differences in other components of cost, including rehab, skilled nursing facilities, or other outpatient costs. Those will come into play in some later studies. But again, a large cost offset related to hospitalization. So when we added this together, the follow-up costs plus the initial costs, the net cost at the end of 12 months was about $52,000. So that is, again, the price we had to pay. The question is, so what did we get? What was the benefit to the patients and to society of that additional cost? And the benefit was both improved survival and improved quality of life. And at the time when we did this analysis, these were the survival curves. We had about 2.5 years worth of data when we started to do this economic analysis. But as you can see, those curves aren't the whole story. If we were just to stop counting there and say, what was the gain in survival or the gain in life expectancy, we would have underestimated it, because that's like making the assumption that everybody dies at year 2.5. What we had to do in order to really understand the cost effectiveness of TAVR for these extreme risk patients is we had to mathematically fit curves to the observed data, then extend those curves over the theoretical lifetime of those patients. It turned out we had the opportunity to check our math when we got the 5-year data, and we got very, very close, within a couple percent actually of the 5-year data. So when you project these survival curves, then we can integrate the area and add up the area between these two curves, and that area is the gain in life expectancy. And what you can see here is the survival with TAVR in these extreme risk patients was about 3.1 years. With medical therapy was much shorter, about 1.2 years. So the difference was almost 2 years, about 1.9 years of life expectancy gain. And so now we actually had enough information, having, again, analyzed the survival gain and the costs, to put them into balance and to show them on this grid. And I'm going to show you several graphs that look like this, so it's worth my just spending a minute to explain what this graph is. So this graph is going to show on the x-axis the gain, in this case, in life years or quality adjusted life years. Points to the right of the unity line have improved survival and greater life expectancy. Points to the left have lower survival and less life expectancy. And on the y-axis, we have the difference in cost between TAVR and the medical therapy group. Again, points above the axis are higher cost, points below are lower cost. And here is the data. This is actually what happens. This is the data from the Partner B trial. And every one of these points, these aren't individual patients. These are actually replicates of us repeating the trial mathematically again and again and again. And this cloud of points represents what we call the joint distribution of those two quantities, of the gain in life expectancy and the difference in costs. The first thing to notice is that all of these points are in this upper right-hand quadrant. That's the quadrant where we are improving life expectancy, but we were also increasing costs. None of them are in any of these 3 other quadrants. So we are very confident that TAVR improves life expectancy for these patients and increases cost. And if we look at the central point, the average of all those points, it's a net lifetime cost after of about $79,000 and a gain in life expectancy after discounting of about 1.6 years. And if you divide these by one another, you calculate something called the incremental cost effectiveness ratio, or ICER, which is, again, it's just very simple math. It's just this, this quotient, and it's $50,000 per year of life gained. If we draw a threshold line, this green line represents points that are right at that $50,000 per life year gain threshold, and you can see it really bisects that cloud. Half the points are above and half the points are below that. But if we put another threshold, $100,000 per year of life gain, you can see that all of the points, again, are below that. So we are very confident that the cost effectiveness of TAVR for these extreme risk patients is less than $100,000 per year of life gain, and it's somewhere right around $50,000 per year of life gained. Now, when we show these results, I was very excited to see these results, because this actually is a very reasonably cost-effective therapy. Even though these patients were old and sick and challenging, this was very reasonably cost-effective. But the sponsor, Edwards, was maybe not, they weren't as excited as I were. They wanted to know, why didn't this save money? We have this great therapy. It really reduces hospitalizations for these patients. It makes them live longer. So why isn't it saving money? And it turns out, when you look at what the data are, the reason TAVR doesn't save money is actually 2 things. Number one is the control patients. So the control patients are very sick. They're very expensive, but they die very quickly. And as a result of that, they actually don't have time to incur a lot of costs. The second point, though, is equally important, which is the TAVR patients, even when you do a TAVR on them and you cure them of their aortic stenosis, they're very expensive to keep alive. And why are they expensive to keep alive? For the exact same reasons that they were extreme risk. They have a lot of comorbidities. They are an elderly group. The mean age here was 84 years. And so these patients, when they live, they aren't free to our society. And so that's why TAVR doesn't save money. And in fact, you can you can actually reanalyze the data, take away the entire cost of the valve, take away those $32,000 that the valve cost, and it still doesn't save money because of how expensive it is to keep these TAVR patients alive. And so it's important to recognize that we aren't necessarily going to save money with TAVR. We are going to buy lives. We are going to increase life expectancy at a reasonable cost. Now, what is reasonable? Well, in the United States, there's actually a fairly good consensus as to what's reasonable. The AHA and ACC put out this consensus paper about 5 or 6 years ago, where they defined high value therapies as $50,000 per quality adjusted year of life gained or less. And again, between $50,000 and $150,000 per year of life gain, that's intermediate value. And only when we get above about $150,000 per quality adjusted year of life gain do we have low value. And so where is TAVR? Well, TAVR is right on this dividing line between high value and intermediate value. Again, a very reasonable price to pay for therapies in the United States. So that's the extreme risk population. Again, higher costs, a substantial improvement in quality adjusted life years, and again, achieving intermediate to high economic value. Now let's just move down the risk spectrum a little bit. The next study that we did was the very high risk patients. This was the Partner A trial, patients who were high risk for surgery, but were surgical candidates. And when we analyzed the cost effectiveness in that trial, what we saw was the costs were actually similar, or perhaps very slightly lower, but generally similar with TAVR as surgery. The quality adjusted life years were actually very slightly increased, not because of an improvement in survival, but because of the short-term improvement in quality of life that was seen with TAVR. And as a result, similar costs with improved quality adjusted life years. That's what we call a high value or a dominant strategy. So again, a very, very good, reasonable value for money in the very high risk group. The next study we did was we moved a little bit further down the risk spectrum into the high risk. This study was the Medtronic high risk trial. Again, the extreme risk patients, these patients had an STS risk score that was off the charts. The very high risk patients, Partner A, STS risk of about 11%. The high risk patients who were enrolled in the core valve high risk trial were about 7 to 8%, so a little bit lower risk. In that trial, once again, we didn't see cost offsets. We saw a modest increase in costs with TAVR compared to surgery, but we also saw improved survival, at least over the first couple of years. And when we looked at the ratio here, again, it was intermediate to high value, right around that $50,000 per quality adjusted year of life gained threshold. Until very recently, that was all the data we had. But obviously, over the last couple of years, we've really moved into treating the intermediate risk patients. And we had the good fortune to be able to do an economic study of the intermediate risk patients as well. And I think one of the real key things that we've learned from the intermediate risk patients, and I think one of the true miracles of TAVR, is how good TAVR is in those intermediate risk patients. In fact, from an economic standpoint, and I would venture from a clinical standpoint as well, the intermediate risk patients are probably the true sweet spot for transcatheter aortic valve replacement. So I want to now just kind of go over some of the data now from the Partner 2A trial. This was again published a couple of years ago. We presented it as a late-breaking trial about 3 years ago at the the TVT meeting. But this is from Partner 2A. It was a comparison of the XT valve, second generation balloon expandable valve, versus surgical aortic valve replacement. You can see the procedures were much shorter with TAVR. The length of stay was about 4.5 days shorter, including a little over 2 days savings in the ICU, which is very expensive. And actually, interestingly, there were not a major difference in pacemakers during the initial hospitalization. So substantial reductions in resource utilization. So where did things come out in terms of the initial costs? Well, the procedures themselves were clearly much more expensive with TAVR by about $22,000, driven almost entirely by the cost of the valve. But over the remainder of the hospitalization, there were about $18,000 worth of cost offsets from a reduction in length of stay, complications, ICU length of stay. There were a little bit further reductions, about $1,500 worth of cost savings on the physician side due to reductions in anesthesia costs predominantly. When you added these together, TAVR was close, but not quite cost saving. So again, the cost difference that was there of $22,000 was now down to about $3,000, but still a little bit more expensive for TAVR during the initial hospitalization. But what was the real surprise in this trial was what happened over the next 2 years. These data came actually from linking the trial data to Medicare data. So these costs that I'm showing you here are actually what Medicare paid for the care for these patients for the next 2 years of follow-up. What we saw again here was really miraculous. we saw that between discharge and 30 days, there was about $3,800 worth of cost offsets. Between 30 days and 6 months, there was another $7,000 of cost offsets. And then things kind of flattened out. From 6 months to 24 months, things were pretty flat. What was driving these cost offsets was really two things. One was the avoidance of the need for cardiac rehab, which again, in intermediate risk patients undergoing surgery is very substantial. And the other was reductions in rehospitalizations that, again, we all know that our surgical patients experience at least during the first 6 months or so. And so the 2-year follow-up costs were actually about $9,000 less for TAVR than for surgical aortic valve replacement. And so now when we added these together, here is this cost of the initial hospitalization in red. Here's the cost of the follow-up hospitalizations in yellow. And the total 2-year costs weren't higher. They weren't even equal. They were actually $6,000 less with TAVR than surgical aortic valve replacement. So again, really, this is the first time we saw real cost savings with TAVR, achieved really mostly from the reduction in follow-up costs. And when we put this data together into the cost effectiveness framework, now we're not in this upper right-hand quadrant. Remember, in the case of the Partner B trial, the extreme risk patients, we were all in this upper right-hand quadrant. If you look now at Partner 2A, we are almost all down in this lower right-hand quadrant. What's in this lower right-hand quadrant? This is where we were improving survival or quality adjusted life years. Again, a little bit on the survival side, a little bit on the quality of life side, and we were also saving money. This is why I say it's the true sweet spot. And in fact, when we projected this over a lifetime, we're saving almost $8,000 per patient. We're gaining about 0.15 quality adjusted life years. And this is what we call an economically dominant strategy, saving money and saving lives. And in fact, there's an 84% chance that TAVR is an economically dominant strategy for these intermediate risk patients. And if we look at the threshold of $50,000 per quality adjusted year of life gained in the green line here, again, you can see that not a single one of these yellow points is above or to the left of that. And that means we are 100% confident that we are achieving high economic value with this therapy. So again, really a miracle from my perspective from this technology in their intermediate risk population. So again, we've got some really good news in terms of the economics of TAVR, but there is some, so there's always a little bit of a dark cloud, and and it's not a perfect story. Another important economic insight is that although TAVR really is cost effective for most high risk and intermediate risk patients, there are still some important exceptions that we have to keep in mind. So when is TAVR not cost effective? Well, if the life expectancy after TAVR is brief, in particular, if it's less than about 3 years, it's not particularly cost effective. And why I say this is this analysis we did. This is what we call a sensitivity analysis. And what we're doing here is we are varying the life expectancy that the patient would live after a TAVR, and we are seeing how that affects the cost effectiveness ratio. And obviously, the longer a patient lives after TAVR, when we compare that to medical therapy, the better and the lower the cost effectiveness ratio. If we're willing to spend $50,000 per year of life gained, you can see here, this is telling us that our patients need to live at least on average about 3 years after TAVR to achieve that. In the United States, we're often willing to spend $100,000 per year of life gained. So maybe about 2 years of life expectancy would be about the minimum. But obviously, if you have a patient who's only going to live a year or so on average after you do a TAVR, you can see that cost effectiveness ratio is pretty much off the charts. And that's why, again, the recommendations for TAVR, the guidelines, the label says, TAVR should only be performed in patients who, stand to achieve a substantial benefit from TAVR. A second time the TAVR is not cost effective, and one I think that we tend to think about as clinicians quite a bit, is when quality of life doesn't really improve. And what I mean here, well, here are two clouds of data. The yellow one is the data I already showed you. This is from that Partner B extreme risk trial. And then what we've done now in the orange points is we've actually reanalyzed the trial data, allowing the patients to live longer, but saying, let's assume they don't feel any better, giving them the same quality of life they had and not letting it improve. And what you can see is all these points are shifted to the left. And that cost effectiveness ratio, which was right around $50,000 per year of life gained, is now around $80,000 per year of life gained. And it's getting close to the margin where we're saying maybe it's getting to intermediate or questionable value. And so this is why I think all of us who do TAVR, really want to make sure that we're benefiting our patients, because if you're not going to improve their quality of life, even if you make them live longer, they're probably not, it's not going to be very cost effective. And so this is sort of trying to hone in on that cohort C, and we can talk more about that if time permits. And then the final area where TAVR is not very cost effective is one for the surgeons, which is when surgical AVR is equally effective and less costly. Well, you may say, well, you showed us a lot of data. I didn't see any place where surgical AVR was equally effective and less costly, but that's because I was really focusing in predominantly on transfemoral TAVR. And if we look again at that intermediate risk trial, remember this was the sweet spot trial, the Partner 2A trial, and we look at the transfemoral group, the patients who were eligible for transfemoral access. Not only is TAVR cost effective in that group, it's actually more cost effective than in the overall trial. The cost savings in the transfemoral patients in the Partner 2A trial, the cost savings were almost $12,000. The gain in quality adjusted life years was about 0.3 years. And you can see, again, this is extraordinarily cost effective. On the other hand, what about the 23% of patients who were only eligible for alternative access? Remember, in Partner 2A, all of those patients were treated transthoracic. They either underwent transapical or direct aortic access. And in those patients, you can see all of this cloud of points is above and to the left of this line, meaning the cost effectiveness is not favorable. And in fact, if you look at the average point here, it's more costly by about $4,500, and the quality adjusted life years are actually less. So in this case, TAVR is not cost effective. In fact, it's what we call economically dominated, because surgery is actually less costly and more beneficial. And I think this really tells us that, again, transthoracic access, if that's all you can offer a patient who needs an aortic valve replacement, you really need to think twice as to whether TAVR is the right thing to do. They probably should just be getting surgery, because it's going to save money and probably contribute to making them live longer as well. Well, I want to take the last 5 minutes or so and talk about the horizon, what's coming next, because we've talked about extreme risk, we've talked about high risk, we've talked about intermediate risk. And as we all know, the big slice of the pie in aortic stenosis is not the high risk. That's about 6% of our patients. It's not the intermediate risk. If you define that strongly, clearly in the surgical series, it's about 14%. The vast majority of patients who undergo aortic valve replacement in the United States are in this low risk category. And so the economics here are going to be particularly important. So what would be the economic justification for a low risk TAVR? And again, I think this is a very important issue, and one we're going to have to face for many years. Is it going to be a survival benefit? I think if we're honest, we'd say that's pretty unlikely. We've seen the 2-year data. They've been published now from Partner 3. There's already, the curves, the survival curves are pretty much superimposed. It's unlikely they're going to spread apart further. So I don't think there's going to be a survival benefit from low risk TAVR. Is there a quality of life benefit? Well, yes, we've published this. My colleague, Suzanne Barron, published the quality of life data from the Partner 3 trial, and there is a quality of life benefit, but we know from other studies that it's only going to be in the short term. It's not going to be a very long-term benefit. Are there going to be cost savings? Because if we don't have a big survival benefit and we don't have a quality of life benefit, then we better have cost savings. And the truth is that it may be challenging for us to demonstrate cost savings given the cost of the valve, again, about $25,000 more than our surgical valve, and the excellent outcomes of SAVR for the low-risk patients. So how are we going to generate enough cost savings to be able to afford TAVR for our low-risk patients? And again, there are several different insights that we've gained over the last decade that can translate into the modern era in terms of how we're going to, how can we control the costs? I obviously talked already about avoiding transthoracic approaches. We really don't want to do that for TAVR. Perhaps some of the newer approaches that don't invade the chest, like subclavian access, transcarotid access that we did a lot of up at the Mid-America Heart Institute, even transcaval access possibly would be a better solution for patients who need alternative access. Obviously, a second thing we want to do is we want to select our patients well. We don't want to treat cohort C patients. But I want to focus in for the last couple minutes on these last 2 points. We definitely need to focus in on preventing complications, especially bleeding and acute kidney injury, and I'll show you why in a second. And the second thing we want to do is we want to reduce the length of stay for our uncomplicated procedures by fast tracking or through taking a minimalist approach. So let's focus in on just these last two things, because I think these are really the key to figuring out how we're going to be able to afford to do low risk TAVR. This is a study we published about 5 or 6 years ago. Another colleague of mine at Mid-America Heart Institute, Dr. Suzanne Arnold, did an analysis from the early partner trials where we looked at the cost of complications. So this is a regression model where we are looking at patient characteristics, but importantly, the complications that occurred during the initial hospitalization, and asking how much did each of these complications add to the cost of taking care of the patients. And you can see that complications of TAVR are not cheap. Even death doesn't come cheaply. Death cost about $40,000. A major stroke, again, during the index hospitalization cost about $16,000. Major bleeding added about $32,000. Acute kidney injury, $68,000. So you can see these huge costs when patients had complications. A repeat TAVR, having to do another TAVR during that hospitalization for paravalvular leak or for some other complication, also very expensive. But what we really wanted to understand when we did this study was not just the cost of each complication, but also what their frequency was in the partner trial. And when we multiply the cost of each complication by its frequency, we come up with these numbers here in the last column, which I call the attributable cost. What these are really is what, on average, each of these complications is adding to the cost of the average TAVR patient. Or you can think of it, if we could completely eliminate that complication, how much money would we save the hospital? And what you can see here is there's several complications that if we could completely eliminate them, we would be able to save a lot of money, and we could afford a lot of embolic protection devices or fancier valves or other sorts of things that we might want. And in particular, major bleeding, not because it's heroically expensive, because it was very common, especially in these high-risk patients. And arrhythmias, pacemakers mostly, which added another $2,600 on average to the price tag. So if we kind of take the big step back and we look at those data, in the early days, in the high-risk patients, in the intermediate-risk patients, what was driving the cost of TAVR? Well, obviously the valve. The valve was quite costly, about $30,000, $31,000. Complications, if you add together all those costs on the previous slide, add about another $11,000 to that cost. And what's left over is everything else. And so what does this mean? So complications are accounting for about 24% of this pie over here, of the non-implant related costs. So complications, avoiding them, we can really save a decent chunk. But what you can see here in the blue is that the even greater opportunity for savings would come from maximizing the efficiency of care for uncomplicated admissions. Again, in these high-risk patients in the early trials, it was about an 8-day length of stay. If we can get this down to 1 or 2 days, we're going to save a lot of money. And that's actually what was shown in this study that the Emory group published, again, about 4 or 5 years ago, where they were pioneering the minimalist approach. And many of you who do TAVR know that the Emory guys were really one of the first groups to really take things to the next level in terms of minimalist. So they studied 142 patients, all of whom underwent a balloon expandable TAVR by a transfemoral approach. The first 72 of them had their standard approach. They were treated in hybrid OR with general anesthesia, femoral cut down, TEE, ICU recovery, and then the next 70 were treated by a minimalist approach. They just stopped and switched over to a minimalist approach. Everything was done in the cath lab, minimal or local anesthesia only, no TEE, percutaneous access, ICU or step-down recovery. These are the things that most of us are trying to do these days to maximize the efficiency for our patients. And what they saw was no differences in procedural success, 30-day mortality or other complications, but marked reductions in resource utilization. So marked reductions in procedure time, the time in the cath lab room, their length of stay dropped from 5 days to 3 days. The ICU length of stay dropped, and the hospital cost dropped by almost $10,000, which again was very highly statistically significant. So again, this really shows the opportunity that we have with minimalist TAVR, and hopefully most of you are doing this or doing something very close to this these days. So what does this have to do with low-risk TAVR? Well, as I said, it's very unlikely we're going to see differences in life expectancy or quality-adjusted life expectancy for TAVR versus surgical AVR, or any differences we see are likely to be small. And therefore, it's very clear that whatever value there is in low-risk TAVR is going to be driven primarily by the cost differences. Where are the cost offsets going to come from? Well, we're going to have to see some reductions in procedural costs through some of these minimalist techniques like reducing the number of personnel and anesthesia costs. we have to, we're going to have to see substantial reductions in length of stay. And we're also, just like we saw in the intermediate risk patients, see substantial reductions in rehab and rehospitalization. And so pretty clearly, continued simplification of the TAVR procedure as well as post-procedure care are going to be essential if we're going to be able to justify low-risk TAVR in the United States. Either that or the price of the valve is going to have to drop. And in fact, if you look around the rest of the world where healthcare is generally less expensive, there's almost certainly going to need to be reductions in the valve pricing in order to really offset the cost and to make TAVR reasonably cost effective for these low risk patients around the rest of the world. But I think in the United States, we may be able to get there even at the cost we are right now, if we can just achieve all of these simplifications, all of these reductions in post-procedure complications. We are actually right now underway with the economic analysis from the PARTNER 3 trial. We will have 2-year data, and I hope to be able to present that to all of you guys and publish it right around the time of TCT next year, so stay tuned. So final thoughts before we get to the cases, which is what you really all wanted to come for. The first decade of TAVR, which I've really been a privilege to participate in, has witnessed remarkable improvements in both clinical and economic outcomes. And if any of you started doing TAVR in 2010, 2011, like I did, it's night and day. I mean, it really is a completely different procedure than it was back then. And with these improvements, TAVR has matured from what was originally a risky and costly procedure that caused me to lose a lot of sleep every night before I did one of these, that was reserved really only for the highest risk patients, to one that now saves both money and lives for most of the patients with severe aortic stenosis, at least within the confines of the United States healthcare system. But as I just said, the acceptability of TAVR for low-risk patients is almost certainly going to require demonstration of cost savings, assuming comparable long-term survival. Stay tuned. Hopefully this fall we'll have the answer to that, and I hope it's a good one. With that, I will stop, and you can either take questions or we can go over to the cases, whatever Dr. Malik says comes next.
Dr. Cohen, thank you so much. That was a very nice, concise, comprehensive review of the economics behind this. We have one question that popped up so far, and this is actually from a cardiothoracic surgeon, and she reports that this is very interesting and compelling data. However, it seems to be derived just from the clinical data trial data. How do you extrapolate, see this in the real world? And I would ask all the panelists at this point to unmute your mics, and please feel free to comment.
I think it's directed probably at me. So I think that's good. It's a good question. I think one of the things that is nice about TAVR compared to a lot of the trials that we have, the TAVR trials are pretty close to mimicking the real world. And if you think about it, the TAVR trials in some sense are probably worse than the real world for TAVR, because each one of these trials was testing, first of all, except for PARTNER 3, the latest one, none of them have, none of the ones that I discussed so far really tested the current technology with, 14 French, 16 French sheaths, minimalist approaches. They were much more involved, and especially the early TAVR trials. Again, they were the 22, 24 French sheaths. So surgery always continues to evolve, but it's kind of evolving slower. TAVR has evolved dramatically over that time frame. The other thing about the TAVR trials, if you look at them, because of the way TAVR was regulated, unlike things like, if you look at the surgical versus, CABG versus drug-eluting stent trials, they involve very specific patient populations, and we know that there's a lot of selection going on who gets into those trials. In the TAVR trials, I don't know if any of you were involved in them, but I was involved from day one. Every patient, these were very real world, because the only way patients could get TAVR was to be in these trials. And so I believe, that the data show pretty clearly that the TAVR patients, are pretty much representative of what we treat today, and the TAVR outcomes are probably a little bit worse. So if you asked me to make a bet as to whether TAVR is more or less cost effective than we've shown in the data from the trials, I would say it's probably a little better. But that's a guess. It's not definitive, because we don't have control groups that are so eligible. The thing about TAVR is it's taken things over so quickly that I don't know if you could, if you wanted to look at a database study, if you could get comparable patients anymore. I think the patients who undergo TAVR are a specific group, and the patients who undergo surgery are a distinctly different group, who have a specific reason for undergoing surgery. I don't know if anybody else has any other thoughts, maybe not on the economic side, but about the clinical side.
I agree with you, Dr. Cohen. Basically, structural heart disease in general and TAVR in particular is very regulated. We still report to the same registry. We still collect the same data. We do the same set of tests. We go TAVR everywhere. They still do most of the time. Now with the low risk, it's a little bit different, but we do the pulmonary function test, the carotid ultrasound. We still do the same kind of practice and then put the same data input into the same registry. And it's the practice is built on the clinical trials, and we still do the same thing. So I think just talking about the TAVR population, it's very close to the trials.
Yeah, I think it is pretty close. I mean, obviously the place where it isn't are the patients who've been excluded from the trials. So
True.
we don't know anything, so I mean, I think we have to be honest and say we don't know doodly squat about, TAVR versus surgery and bicuspid valves. We really don't.
True, but
And we don't know, much about, TAVR versus surgery in patients with severe aortic stenosis and extensive multivessel coronary disease. I mean,
Right.
those areas, I think it's fair to say that, that's a data, it's largely a data-free zone for TAVR. And I think that's, a lot of the concerns these days is, are we venturing too quickly into these data-free zones without data? And maybe one of the cases, I don't know if there's going to be a case of a bicuspid valve that we'll get to discuss, but if there isn't, we can, certainly talk about it. But I do think that's, that's certainly important to recognize, is there are holes in our data. And so the data that we have, don't apply to everybody. And in fact, I certainly think there are quite excellent, indications for surgery today, despite how good TAVR is.
the one other point I wanted to mention is nowadays when most of the programs with experience are switching to a minimalist approach, which was not done in the trials, especially in the high risk and low risk trials. So actually there's potential for more savings there. So that's why I think, again, I agree with you. There's holes in the data and all that, but that it might look actually better if you do a real world analysis, especially in.
No, I think so. And we actually have a paper, a study that's upcoming. We're going to be submitting it to, hopefully as a late breaker, to TVT to present this summer, where we compared the resource utilization and the costs in the 3M trial. So this was the Vancouver minimalist study where they did local anesthesia, no anesthesia, not even conscious sedation, just local anesthesia, TAVR, rapid, discharge, aiming for a 1-day length of stay. And we have some pretty interesting cost data from that to share with you guys. So stay tuned. That'll, you might be right, Ahmed.
I mean,
Okay,
as Dr. Ahmed said earlier, our program at Baptist is also mostly a minimalist approach, and almost 95% is conscious sedation. We just do very rarely general anesthesia, and 80% or 85% discharge in the next day.
Yeah, I think it's, I think we've really, figured out how to do TAVR at this point. A lot of places have. The median length of stay in the United States is right around 2 days now, which is, I think, reflecting the same. Where we don't do, and again, I mean, we haven't done it either. I don't know if any of you are doing true minimalist. So true minimalist means, not propofol in a, sleeping, snoring patient. It means an awake patient you're talking to. And we haven't done that. Is anybody doing that regularly?
So, Dr. Cohen, this is George Alvarez. Thank you very much for that. That was a great discussion. Interesting to your point, I think minimalist approach is different for every location. I will tell you that in our institution, I would say 90% of ours are still general anesthesia, but extubated in the OR, awake in the postoperative room, go to telemetry, and then go home the next day.
So you can do almost everything the same with general anesthesia, is what you're saying.
Right. And necessarily not have an issue. We've actually had a handful of cases right now because we have a new anesthesiologist that comes in and actually does a spinal block. So spinal block in the lower quadrant, they feel nothing below, because really when they're conscious, a 14 French sheath, I don't care if you're slightly awake or just a little awake, it still hurts,
I'm sure it does. I haven't had one, so
right. Neither have I. And
the
so
patients do groan. You're right.
And so they actually do a spinal block, and they just lay there, and it's actually worked out. We've done that with our high risk COPD patients.
Okay.
We don't want to intubate. So it's
We
worked out.
published a paper on spinal blocks, actually. I mean, it wasn't my experience, but it was Josep Rodas-Cabot from Quebec in the early days. Spinal, using epidural. I think it was epidural, or maybe it was a spinal anesthesia. I can't remember which. For patients having alternative access for transapical, and saw it was an observational study, but saw lower mortality with it. It was interesting.
Yeah, and so when I say spinal block, they don't roll them over. It's actually, they go anteriorly. The anesthesiologist will sit there and just kind of do this anterior approach into there, block the nerve, just I guess the same way they would do.
How many structures do they go through to get there?
No, I don't know. So it would be a great discussion for our anesthesiologist.
There's a lot in the way. I don't know.
Yeah, it's actually pretty impressive though, because they just lay there, they don't feel a thing. But
wow, okay.
Very interesting to see them, respond to that. But again, I think this minimally invasive or less invasive approach has a different definition depending upon the facilities and what you have available to you.
Yeah, I mean, there certainly are, most centers in the United States today are doing something without general anesthesia, but there still are a good quarter, I'd say, or a third. We published a paper on this actually earlier this year, looking, at the TVT registry and the anesthesia types. And there were, again, it was, there's two camps. I mean, some hospitals were 90%, conscious sedation, and some hospitals were 90% or 100% general. Sounds like you were one of those other hospitals.
Absolutely.
90% general, but I think you're right that you can, the fast track principle still can apply to those patients, which is great.
Okay, I'm going to need to move us along a little bit.
Sorry, yeah, I can talk forever.
No, that's okay. We got plenty of time for questions at the end of the case. I'd like to introduce my good friend Chris Pickett, currently at Brooke Army Medical Center as the chief of the cath lab at there. He is a fellow Army brother in arms, also a very skilled structural heart doctor, and he's going to present the first case for us.
Great.
So Chris, if you want to share your screen, please.
All right,
Here we go.
Uh-oh.
We can't hear you at the moment.
He has to share his screen first. So, Dr. Cohen, while we are at it, there was a question from one of the attendees, is that with low costs and improvement in outcomes for low-risk patients, can we see same-day discharge for TAVR?
Man, he's my IT guy.
Okay, here we go. Chris is back online.
Okay.
We're checking to make sure you can hear us.
Yeah, Chris, we've got you now.
Nod your head up and down if you can hear me.
Yes.
Okay, Dr. Malik can hear me. Yay, Dr. Malik. Okay, so yes, hello, I'm Chris Pickett. I am the cath lab director at BAMC, Brooke Army Medical Center, San Antonio Military Medical Center. And I was gonna, our case we want to talk to you about today is not super exciting, but it's a question that we've had. And I understand from talking to Dr. Alamani that you, Dr. Cohen, and of course, Dr. Alamani as well, have a lot of experience. One of your specialties other than cost effectiveness analysis is sort of valve. And Dr. Alvarez, of course, has a lot of experience, and we'd love to hear from him. And our specific question is, with TAVRs and SAVRs, when do you guys snorkel and how do you snorkel? And so I just brought a simple case that we had. There was a valve-in-valve, stentless valve. So I'll start with the case presentation, show you some of the images of the case, nothing exciting really, and then kind of go over my few questions, and then open to all the experts that are here. And thank you for coming to tell us what they do and how what they would approach it. So
I would say if there's nothing
was a
exciting,
25-year-old robust nurse from Corpus Christi Naval Air Station. He was retired from the Navy. History of CABG, also history of bicuspid aortic valve with an aortic aneurysm that had a root replacement, a hemiarch with a 29mm Medtronic Freestyle, complete root and stentless valve with coronary buttons. And he had a normal EF, very dilated.
Chris, have you shared
your screen, please?
Co-surgeon Dr. Graham, who's now moved on to Bend, Oregon. They went back and forth, the two of them, about whether or not they're going to redo and redo.
We're working on it. Chris.
Severe AI. I know this is again off-label, or we just do a
Dr.
TAVR.
Pickett, you need to share your
to
screen.
help the gentleman.
Let me try to
Can't hear me,
share
so-
your screen real quick. Hold on 1 second, guys.
Is there a reason he can't hear us?
It might be at a restaurant or somewhere out when a smaller group of
Share
people.
screen. Disable. So we're getting a message that says the share screen option is not available.
Yeah, it's the same thing that I had.
So
Okay, so hold on. Let me see if I can fix that.
Can you guys hear us? Chris,
Yes.
can you hear us? You can hear us or not?
I said when he gets back online, we tell him we told
We
him
can hear
the
you now.
answer.
Can you hear us?
Yeah, we can hear you. It just seemed like Chris
Okay.
couldn't hear us.
Can you,
I
we're
can
gonna,
hear
we're
you.
gonna share the screen now. So let's see. It says host disabled participant
Participant
screen
screen
share.
sharing, yeah.
So let's see if we can,
I just promoted him to co-host.
okay. Let's try this again. Share. Can you see it now?
Yes, we're good.
Yes.
Okay, and we can hear you too, so we're gonna go ahead and go from here.
Should I start over?
Yeah, if you would,
Please.
please.
Yeah, right,
There
okay.
you go.
So I'm Chris Pickett, Cath Lab Director at BAMC. We have a short, very unexciting case, and we wanted to get sort of the experts' thoughts on all this stuff. We know what we've done, but we'd like to hear what other people do around the world. And Dr. Alamani said Dr. Cohen is like the valve and valve expert. So here's a valve and valve case for us. 55-year-old guy had bicuspid aortic valves with root replacement, freestyle complete root stentless valve in 2012. Is a 29 millimeter Medtronic freestyle valve. Had severe AI now. He's been having progressive shortness of breath, severe symptomatic aortic regurgitation with some moderate aortic stenosis. So after going back and forth with the surgeon for a while about what to do, they decided finally just to do TAVR instead of a reduced sternotomy. And because of the stentless valve, we've had some experience with stentless valves that, sometimes we don't know if it's a snowplow of this valve in the valve tissue into the left coronary, or it hasn't. We're very careful. We wanted to make sure we snorkeled ahead of time. So I don't know, why is this moving on here? So hold on. Spilling with my IT. Here we go. So pre-deployment of the valve, we snorkel into the valve. And then let's go to the next slide, which I think is this button.
You can either.
Okay, there we go. Now after the valve is in, we did a root shot. Of course, as you can see in that root shot, we aren't demonstrating that the left coronary has flow, so we're a little suspicious. Quite simply put, we just, let's go to the next slide, which would be page down. We just kind of slid our guide liner we had in there back down into the cusp, and you can see it was wide open. We had coronary flow. So we elected not to deploy a snorkel valve because we didn't see that any of the leaflets were impinging on the coronary ostia. We were pretty happy with flow. The patient was doing hemodynamically spectacularly. So we just left it in place. And ultimately we pulled it out to see that still good flow in that, neo button in the stent, the conduit that was placed by the surgeon in 2012. So we're pretty happy with that. But before the procedure, this kind of comes down to why we'd like to ask you all for your thoughts about this is sort of a few questions, and then anything you think you might want to add as experts of valve and valve. When do you guys choose to pre-snorkel? I would say in our group here at BAMC, we choose to pre-snorkel, especially if there's a low coronary ostia, very low. If the patient has a stentless valve, we will pre-snorkel for sure. And then what is your procedural sequence? We found that we get the valve in place, and then it's a little easier. If you have the valve, the snorkeled before you put the valve in, sometimes the valve and guide interaction will pull everything back out, and you just end up having to do it anyway. So we've kind of taken to putting the snorkel in after we get the valve across, if the patient will tolerate that hemodynamically. And then any other tips or tricks or questions from anyone else in the audience about how you handle these sort of valve and valve, this specific valve and valve situation.
So this is, thank you for presenting that. These are tricky cases. They always, first of all, the freestyle valve is, super tricky because you can't see it. And so that's, unless it's, all calcified, and with a lot of AI, it can be difficult to localize it. So I think that's, number one. I don't necessarily protect every freestyle valve, and certainly not every valve in valve from it. The things that, that you want to look for that are the biggest risks for occlusion are, again, you look at the coronary height. So the low coronary height, certainly is a concern, especially if the sinus is not very big. So ideally, you like to see, that after you put in whatever your virtual valve is that you're going to put in, if you put that on the CT software, you want to have at least 3 or 4 millimeters of valve to coronary clearance. So you want there to be adequate distance once the valve is in. So that's, simulating what it's going to look like can be very helpful, but that doesn't necessarily answer everything, because if the valve is very bulky, has a tremendous amount of big calcified nodule on it, it can still occlude. So you have to take that into account as well. The other places where I would be very careful and think about protecting the coronary are the valves with externally mounted leaflets. So the MitraFlow trifecta group, where the leaflets are outside of the valve frame, those have a high, those tend to have very low riding coronaries very often, and there's a higher risk of coronary occlusion. So when we see those, we also worry about occlusion. Ahmed, what do you think? Do you remember anything else from fellowship that we taught you about when to protect the
Well, I definitely agree with you. The freestyle valve is much more tricky than any other valve, and you can't see it on fluoro, and it comes with different configurations. So sometimes they take to replace their root. Sometimes it's just the valve, and and it sometimes comes with its own coronaries, and sometimes it doesn't. It's just every time I see one, I'm surprised how different it can be. The thing is, the CT analysis is the key, and having the ability to look at the whole aortic complex, and assess the risk of coronary obstruction is important. So first thing, like the virtual valve to coronary distance, and also the length of those leaflets, and also, if there are sinuses on that valve. I've seen, valves that kind of chimney-like straight valves, and I've seen ones that had a little bit of sinuses, especially the ones that they come with their own pre-mounted coronary buttons. So all that taken into consideration, you may want to predict if the coronaries are low, leaflets are long, and there's no much sinuses, and also the STJ height. Now, if with any stented valve, it's normally easy to tell, and you can measure that height, and see if your coronary ostium is above the post, then you're probably in a good shape. The thing is, the problem becomes really difficult to answer if you want to do it in a stentless valve and you want to fracture it and it's a borderline distance, and this is another discussion. But in a freestyle valve, I would treat it pretty much similar to what I treat a native valve, in my opinion. I look at the whole complex and kind of from that try to estimate if the coronary obstruction risk is high, and if it is, then I would predict. And I would use a similar approach with the guide liner. I've seen you have a guide liner in that picture, and deploy to the core valve to 80, and then take a root shot and see what happens. And if you're still concerned, I will leave that stent in there, finish deployment, and then basically use the guide liner to get the stent out. I think that was a very nice technique, and nicely done.
Yeah, I think again, there are a couple of further tips on the on the snorkeling technique or the protection. So I would call it, just from a nomenclature standpoint, I would say we're protecting the coronary by putting an undeployed stent into the in the LAD and leaving it there during the case, and then snorkeling is the act of deploying this the stent sticking out of the left main, going up alongside the stent frame, or the Europeans call it chimney stenting. It's the same thing. Either way, for that, the idea of using the guide liner to help you get the stent out, if you don't want to deploy it, it's nice. If you haven't used a guide liner and you're having trouble getting the stent out, well, if worse comes to worse, you can always put the stent in. You can deploy it in an undiseased area in the LAD or something like that, and just leave it there if you're having trouble getting it out. I think, one of the things you have to watch out for is just if you post dilate the valve. So let's say you put in your core valve like you did in this case, then let's say the coronary is obstructed or partly obstructed, and you deploy the snorkel. If you end up coming back and post dilating that core valve for any reason, you could really compress the stent and really ruin your whole snorkel. And so if you do that, you really want to do kissing balloons. You want to inflate in the snorkel stent as well as in the valve to make sure you haven't wrecked all your good work. Dr. Alvarez, did you have a thought?
Yeah, so Chris, thanks for showing that case, particularly when we're talking about the economics of TAVR and not using a stent, but during your TAVR. But very similar to what's already been said. And I think Dr. Omani brought up a good point. First of all, it's going to be your pre-planning CT. What do your sinuses look like? How much room do you have? The way you guys went about, and actually leaflet size is probably more important than anything else, right? So, you can measure your leaflets on CT, try to figure out how it's going to bend up, and hope that works. If you're really kind of concerned of the way that's going to happen, some people will do a pre-BAV, just kind of deploy the balloon and just kind of see the way and do a contrasted shot at that point in time and see if you're going to obstruct with those leaflets. If that looks okay, then you're probably going to be fine. But to that point, I think we've learned, and we've done this like Dr. Cohen since 2011, you always plan for the worst and you hope for the best, which is what ended up happening here. You didn't have to deploy this stent. I think the valve choice in here is probably paramount, something that you can deploy at 80%, take a shot and see that you're not going to have an issue is probably the most important aspect here. And so this is kind of my plug-in for this kind of valve in which, that your valve choice really does make a difference when you're trying to figure out these things. And not only that, if you did have to deploy the stent and then having to post dilate, I think Dr. Cohen, we've unfortunately have seen that where somebody had deployed a left main stent and then send them to us for TAVR. And when we end up ballooning using an Edwards valve, and then you just see that little crimp of the left main and they become a little bit unstable, it always makes you work a little bit faster, but you just have to be aware of those things.
Yeah, I think if your stent is protruding at all, again, that would push me maybe towards a self-expanding valve that wouldn't, might not interact. And in those cases, I might even if there's already a stent in the left main, have a balloon and a wire down, so you can re-expand it if it gets crumpled.
Right. Yeah, that was an early experience.
I think all of us, again, those of us who started in the early part of the last decade, have seen, most of the bad things at least once, and sometimes several times.
I'm going to move us on to the second case now.
Okay.
This discussion is fabulous, and we're going to continue this after all of this.
Okay.
But we're getting lots of questions coming up on the chat box, so pay attention to that. We did have one chat box thing that came up that our next speaker is actually going to address. I'd like to introduce Dr. Uman Shah and Dr. Thomas Pollard, both of the Baptist system here, who run their program. And the question came over, it said that, let's see, is there a specific valve to coronary distance under which you would protect the coronaries? And Dr. Charuka wanted to address that. Kieran, are you still on?
You're on mute. You're on mute.
Oh, Kieran's on mute. Okay, let me.
Okay, can you hear me now?
Yeah. Go ahead, Kieran.
Yeah, no. I actually was going to type the answer for the person who's questioning, but it goes back to what Dr. Cohen earlier mentioned. Again, you use your standard coronary heights in any of these patients, at least more than 10 at least, but ideally 12. But another thing to go is, as Dr. Alvarez mentioned, is the size of the valve that you already have. And if your sinuses are 5 millimeters bigger than that, like if your old previous valve is a 25 plus 5, your sinus is at least 30, then you are probably going to be okay. It's not a guarantee, but if it's less than that, you just definitely have to be more careful and have to think about protection and go forward with that.
And especially if you're going to do a valve fracture procedure or something like that, which again, I think might come up if you're thinking about it, enlarging the surgical valve, then you need to make sure there's additional clearance for the, for the size of the enlarged valve. So.
Okay, I'm going to move on to Umang Shah promoting him, and this is really wonderful that now you can actually see our lovely Texas sunset, Dr. Cohen. Umang's showcasing that for you.
All right.
Can you guys, sorry about my voice, but sorry, able to see my screen?
Yes.
Okay. Let me just.
Here you go.
Okay. So this is a 74-year-old male who basically had an aortic valve replacement with a 21 Medtronic ultra porcine valve in 2015. He did well immediately after the procedure, fairly good historian. So he felt that he had good exercise tolerance improvement. About 3 years before, he started having some decline in the feeling of his exercise capacity. Eventually, when we saw him last year, he felt a significant decline in his exercise capacity. So we further investigated his valve, and by the transthoracic echo, the valve area was 0.79 centimeter square. Mean gradient was 42. We did a CAT. The CAT showed 32 millimeters somehow at baseline. We gave some vitamin. His EF was about 40. The gradient was about 47 at that point. There was some concern, dilemma in our mind, that if the valve was truly stenotic or if it was a more of a prosthetic mismatch. So we decided to do a TEE, and I tried quite a bit to get better pictures. But in some of the views, the TEE, like the left leaflet seemed to be moving a bit. We'll play one by one. And the rest of the views, and I try to perform sweep to see if it gives a better idea, but you will see the pictures, and that's kind of where we were. So one of the concern was what imaging studies to use in evaluating this, if CT-based gating would be a better option or not. And obviously then the main point of discussion is what would be the strategy to frac the valve or not, what kind of valve do we use, and so forth and so on. So let me come to the CT findings.
Dr. Shah, can you share with us what kind of surgical valve he has?
It was a 21 Medtronic ultra porcine valve.
Okay.
21 millimeters.
Yeah. One second. Let's see. Let me play this last shot. So this was a workup by Medtronic, and let me go to the next slide. So the perimeter was 17 millimeter. The area was 224.9, but the area for the annulus was bigger. So now the question is, what would be the best choice per se?
You have the images? There you go. Okay.
Yeah. And I do have the both CAT scan workups that I can go through. Everybody's able to see it?
Yep.
Yeah.
Okay.
Yeah. So coronaries are high.
All right. Coronaries are fine. Right.
And this is
You need me to go back?
No, you're okay.
Okay.
20 and 20.
Yep.
It's with a 20
Waist diameter.
The waist
Yeah.
of 20. Okay.
Yeah.
21 mosaic, 18.5. Yep. Okay. Keep going. So let's just stop here. I think because
Right.
the question, so the first question is what's going on? So this guy is having recurrence of symptoms that are pretty significant at this point.
Yes. Yeah.
And he's 74, I think was the age.
Yes, 75.
74-year-old guy.
Yeah.
And he's just 5 years out from his
Out of his
surgical
valve.
valve.
Right,
Is it
correct.
right? It's 5 years out. So that's not normal. So there's three, I mean, if we're going to attribute this to the valve, it's a valve conference. So let's at least, say that we're pretty sure it's not anything else, that his LVDP is okay, doesn't have other bad lung disease or other things that might explain his dyspnea, which is a predominant symptom.
Right.
It's either, and he's got a, moderately high, not a, sky high, but a pretty high mean gradient. So either it's valve degeneration, early, premature valve degeneration
Right.
with stenosis. The second possibility is it's thrombus that is causing, relatively rapid progression and immobility of one or more leaflets. And the third is that this has been there for the most part all the way along, because he got a pretty small valve, and it's patient prosthesis mismatch. And to sort those out, we need a couple of things. We need more, we need better imaging of the best imaging we can get of the leaflets, ideally with a 4D, with a CT that is, a 4D CT, so we can see the leaflet motion, so we can figure out if there's thrombus on the leaflets. That would be, number one. And then number two would be any intervening echoes. Did he have an echo in 2016 or 2017?
Yeah, so the gradients were not this high.
So the
They were
gradient
around
is higher.
20.
So it's
So the gradient definitely has increased. It was like 20 something, but I think then it has increased.
okay. So there was probably a component of patient prosthesis mismatch from the beginning, and now something has gotten worse on top of that, is what you're saying. So that's very helpful, because that tells us it's not just pure patient prosthesis mismatch. Something
Right.
is going on. So if you can't get a great 4D CT and you're having trouble imaging the leaflets, your choices are to re-replace the valve in one way or another, or to give them an empirical trial of anticoagulants. And so, were you able to get any better images? Because I haven't seen anything that tells me what the leaflets really look like.
I can play it back again, but I mean, I spent good
A lot of
30
time.
minutes in this TE, but it won't get any better.
But it doesn't look like really calcified or anything. It just
No,
looks.
no, it doesn't. Let me play one of the view with color and see if it did look like a degenerated valve, but it didn't.
I don't know. I mean, Ahmed, what do you think?
Well, it seems like you said, there's a little bit of patient prosthesis mismatch element from the get-go. He had gradients of 20, something right after surgery, which is unusual. I was just looking at the numbers of the CT. His LVOT dimensions are twice his size if you talk at the parameter. Can you go back to that measurement slide?
Yes.
The LVOT is twice the size of the annulus.
So if you look at this, his area in the LVOT is 470, and the area inside the valve is much smaller. Look at the sinuses, 30, and 34.
Yeah, I mean, it's a tiny valve in this guy. I mean,
I think what the problem is. I think, basically, unfortunately, he got a smaller valve than he deserves when he had the surgery. So, and we know that valve that start with higher gradients, they tend to degenerate faster because of the strain on the leaflets and flow mechanics. So I
might still, yeah. So I mean, I think we're going to end up, having to, replace this valve again. But unless if he's not profoundly symptomatic, I might be, give him a try of, 6 to 8 weeks of Coumadin or of a DOAC, which works really in my mind just as well, and see if the gradient goes down and his symptoms get better. If it doesn't, that's fairly convincing it's not thrombus, and then we're at the point where we have to decide whether we're going to reoperate on him or do a valve-in-valve procedure, which really comes down to talking to the surgeon a bit, and the patient about what he wants. But if if it's not thrombus and it degenerated very quickly, obviously what worries you a little bit about putting a TAVR valve in that is what how sure are we that the TAVR valve isn't going to degenerate very quickly. And so I would at least entertain start by having a discussion with him about the possibility of surgery with a mechanical valve.
So we did discuss that. Dr. Pollard did offer him that. Obviously, he wants to use that as the last option, or maybe not even an option. But I think if we try very hard. He may be convinced, but I mean, he's fairly on the side of if I want all percutaneous option if possible.
Okay.
And I think Dr.
So
Pollard is
Dr.
on the
Cohen,
line.
can I just point out, so with a 4D CT, because we use that as well to look for thrombus, if you saw the leaflets were okay, no thrombus, you would not use anticoagulants, correct?
Right.
Right. If the leaflets are fine, you're
else.
not going to fix
And
that.
I think one of the points here that was not on the presentation was actually trying to figure out this patient's BMI. And I didn't see that, at least I may have looked away.
I didn't see it either.
But in San Antonio, I'm going to tell you that a 21.
So surprisingly, I don't remember his BMI right away, but he's fairly skinny.
Either way, a 21 valve in this gentleman is going to be too small. And even though he may want to have a transcatheter approach, this is somebody who I think you need to push towards root enlargement, putting in a bigger valve, because at 74, and if you put in a TAVR, he will be back with patient, even if you frack it, he will be back.
I'm trying to get Dr. Pollard online right now. I've promoted you, Dr. Pollard, to co-host, so you should be able to share your stuff with us and comment.
Is Dr. Pollard a surgeon, I hope?
Yes, he's the cardiothoracic surgeon involved in the case.
Great.
Okay, well, I appreciate the promotion, I guess. Can you hear me? Is that?
Yes.
Yeah, there you go.
Yeah, I appreciate, again, your thoughts, and certainly enjoyed your talk. Yeah, this gentleman is a very difficult case. And to me, there are negatives for transcatheter, but there's also negatives for reoperating on him. Let me just add a couple of things. First of all, you kind of already pointed out, this was a small valve for this gentleman initially. I'm a little surprised by that, because I was looking at his specifications, and actually, at least I have him listed at 5'3" and 170. So, that's smallish, I would say. But if you look at the surgical tables that we use, and again, those things you have to take with a grain of salt, but it would have suggested that he really needed a 23 valve when he had his surgery, and he got a 21. That being said, when you talk to this gentleman, he felt better after his surgery. I mean, he had symptomatic aortic valve stenosis. He was better after his surgery, and he was better for 3 to 4 years. And it's only really been in the last several months that he's felt worse. And so from that standpoint, you would think, well, gee whiz, maybe he would benefit from a transcatheter therapy. One of the other kind of caveats in this case too, though, at least from a surgical standpoint, because initially when I saw him, I did, when I had this data, I felt, well, yeah, I think a redo root is going to be your best option. But his CT, unfortunately, also disclosed he had a little bit of an interstitial disease. I would say a moderate level of interstitial disease. And to me, that's a problem from a couple of standpoints. Certainly from a surgical standpoint, I worry in what's going to be a pretty long case, taking out a valve, doing a root redo circumstance. That's a tough case. It's a long case. And if he's got interstitial disease, we may struggle a little bit coming off pump. From another aspect of that, though, is that really playing a role in the symptoms that he's having now? And will he, no matter what therapy we do, is he still going to be short of breath? Now, again, it's not the worst interstitial disease in the world. I think radiologists grade it as moderate, but you can definitely see it on a CT scan. So to me, this is a tough one, because the fact that he did tell a pretty good story that he was better after his valve, I think we can kind of say that redo TAVR probably, or doing a valve and valve probably certainly doesn't burn the bridges like a redo surgery would. And so to me, the question is, well, is it worth trying it to see if it makes him better? Or, just say that's not an option and do a redo root. And so to me, he's difficult to know really what the best option is. And so I guess, one of the questions would be, what are the disadvantages of at least trying valve and valve?
So I think,
and just to add to that question, if we do decide to go transcatheter approach, what would be the, technique or steps recommended?
So let's talk about, so I think, first of all, it's fantastic to have the surgeon who's seen the patient on the call, because on this meeting, because there's, no substitute for, actually having talked to, examined the patient, and looked at all the studies yourself. So that's wonderful help. And also the experience of, what it would entail. I think and a root enlargement is not a trivial matter. for him. In terms of a TAVR, I mean, I think you could make an argument, a reasonable argument to do the TAVR. Part of that argument would be that we're not sure he's going to get better if his lung disease is there, and it sure would be a shame to put him through a huge, reoperation with a root replacement, and then he's not even any better. Whereas doing a TAVR on him and he's not any better, it seems like a little less. It bothers you less in that circumstance because you haven't exposed him to the recovery and all those.
Just to add to that point, his interstitial disease has been there all along. I mean, it may have progressed also along slowly, but it has been there.
So you're not so worried maybe about that.
Hey, so Dr. Cohen,
can I tell that it has dramatically contributed or not? But
right.
Yeah.
So Dr. Cohen, wouldn't you say though that obviously we have different degrees of PPM, right? So just because he felt better after surgery, which if you had critical aortic stenosis, and even if you put in a bad valve, you're going to feel better after surgery. Right. So I think we would all agree with that.
Yeah.
And then there's moderate, and then there's moderate, and then severe. We always talk about the severe as having this significant mortality benefit issue and deterioration of the valve at a more advanced rate than not. But he could still very well have moderate PPM, taking him 5 years to develop this. And the question here, though, is that he's 74, and let's say he has had interstitial disease this period of time. And if his interstitial disease is somewhat being treated, and he has, again, PPM in 3 years or 5 years with a valve in, what's the complicated factor with a valve and valve removal at that point in time?
Yeah. So, I mean, the honest answer is I know you asked a lot of good questions and I don't know the answer to any of them. Because,
do I.
Because we don't have good long-term data on valve and valve TAVR. We honestly, the best data we have is a couple of years now that from Danny DeVere is, starting to publish it. And it's not, it's not necessarily a pretty picture. Valve and valve TAVR is a wonderful procedure, for a couple of years. But it isn't a great procedure if you're trying to get, 10 years out of it. And so that's the tough judgment. And I really don't know, I don't know the answer to that. I do think we can get rid, I think we can help with his PPM. I think, we have a TAVR technique that is applicable to this particular patient that would get rid of his PPM, which is to do a valve and valve TAVR with a self-expanding valve, supraannular valve, which will give us the minimum gradient, and then to do a bioprosthetic valve fracture as well in order to expand the valve ring. And that will give us, we will gain, typically we gain about, 3 millimeters in valve size, with that approach. And, between fixing the leaflets with the new valve, valve and valve TAVR, and expanding the valve with a fracture, I think we would be able to get this gradient down to 10, but we're not going to get it to 0. And I don't know how long it's going to last. And so let me turn it back over to Dr. Pollard and say, let's say we do all that. And now 5 years from now, he's 79 and his bioprosthetic, his valve and valve is degenerating. How big an operation is it now to take out, his original surgical valve and the implanted core valve, and do a redo now in a 79-year-old? How bad is that?
However, before we do that, I want to bring Dr. Huey into this discussion. She's also a CT surgeon at the university and our next presenter. So Dr. Huey, if you could start sharing also.
Yes, thank you. So interestingly, our case is about this sort of situation, and a lot of
if you would please comment on the last question prior to moving on to your case.
Oh, the risk. Well, obviously I haven't met this patient, and you'd have to, age in and of itself is not a risk. I think it's the comorbidities, the frailty, the debility, and the decline in function that comes with age. And I think, when we look at AS patients, a lot of them are frail because they've sort of either, the onset of symptoms has come very gradually. And so I think saying somebody is too frail for surgery is a little bit tricky in the AS population. We find, I actually did a mitral in a 70-year-old lady who was very frail, very debilitated. And I think we, especially in San Antonio, ought to pay more attention to prehabbing these people. There's sort of sometimes a fatalistic attitude. I'm just getting older and I'm not going to be able to do anything. But I think prehabbing patients can go a long way towards getting patients through surgery successfully.
What about the explant? We're starting to hear, some data now coming from our surgical colleagues about the challenges of valve explantation. I think the group from the Gilbert Tang, is leading an explant registry that is, suggests that the short-term mortality, the 30-day mortality for at least the first, round of valve explants is, certainly north of 10%, I think around 15% or so. Is that your experience? Or again, nobody has a lot of experience with valve explants, fortunately. But if you could share any experience you have, that would be helpful.
Right. We've only done a few. I think the concern is, does a TAVR valve commit you to a root? And not 100% of the time. I wouldn't even say 50% of the time. Now, some of the explants have been early when the valve hasn't been in very long. And so, of course, those are going to be easier to take out.
Right.
So I
think the
now,
data these days, the explant, I think the Edwards valve, the SAPIEN valve is, more likely to need a root than the self-expanding valves. It's at least, some preliminary data, but you can do it. In other words, it can be done carefully.
Yes. Now, I think, I think explanting a TAVR in a valve, that actually may be easier because the surgical valve is sitting there, and that's sort of the outer ring that you have to take, which we have, a great deal of experience with doing that.
So as long as if the surgical valve is keeping you off the tissue of the root, then that may help.
Yes, exactly.
Yeah, well, I think that being said, though, that does bring up the question, if you do a valve and valve on this patient, which valve would you do? Because I agree with you. I think the self-expanding valve probably is going to have a better hemodynamic profile afterwards. At the same time, if you did have to go back, it's a taller valve. Would you be able to cross clamp the aorta on a redo? And so again, I have no experience of, explanted a lot of surgical valves in my career. I have not had the opportunity yet to explant a valve and valve, or even really to explant a TAVR valve that wasn't in the acute situation, to really know, is it tougher to go back on a self-expanding valve just because it's going to have a taller profile, which in some patients could preclude being able to clamp the aorta and force a circ arrest situation.
Yeah, that would be tough. I guess you'd have to look very carefully at the aorta and see where the valve came to, and make that judgment. And obviously these days we're trying to implant these pretty high. Although valve and valve, you don't have to worry quite as much about implanting it quite as high as you would with a native root. Again, I haven't heard anybody say they couldn't cross clamp with a core valve in. I haven't heard that description. But I think this is why we, again, this explant registry is very important to learn what we can in this circumstance. I certainly, if I were going to treat it, I would still try to do the very best job I could with TAVR valve and valve. I'd put a 26 millimeter core valve in this, not a 23, and I would fracture that 21 millimeter I think it's a MitraFlow with a
Medtronic Ultra.
Ultra Mosaic.
What was it?
Medtronic Ultra.
Oh, Mosaic. It was a Mosaic. I'm sorry. I fractured the Mosaic with a with a 22 millimeter true balloon, and see what the gradient came out. And I think we'd get it. You'd probably have better hemodynamics than you did on the original surgical valve at that point. But the question is, would it last? I guess you guys haven't done it yet. Nobody's treated this patient yet.
We were saving it for this.
You're saving it for us. Okay.
Yep. It just fell in a way that it.
No, it's good. It's good to have this discussion. It's a tough one.
Yeah.
It's not.
I totally agree with Dr. Cohen, and specifically because this patient, if you look at his annulus is big. We would normally put a 26 core valve in there. So that's what we used to choose what balloon to fracture within a lot of times. So he can accommodate a 26 there. You gain 3 to 4 millimeters when you fracture the valve. You get that 17 to 20, 21, and that's the inlet. But you have a supraannular valve that probably is more open. Now you may get the best hemodynamic results out of this, and the question is durability. And when you take it out, will that longer valve interfere with the aorta and the root and cause any problems? But if this guy is a high risk patient, by the surgical assessment, and then he's appropriate for valve and valve TAVR. I would definitely go with exactly what Dr. Cohen said, with 26 core valve and fracture with a 22 balloon, and go from
Well,
there.
I think, so we've given you the best advice we can. It's still, you're still the heart team, and you're going to have to make the tough call.
That being said, I think it's time to move on to Dr. Huey's case so we can take questions at the end also.
Very good.
Dr. Huey,
Thank you.
the stage is yours.
Thank you. So a lot of similarities to the case that was just presented. This is a 71-year-old woman who had an AVR about 10 years ago. It was started as a mini thoracotomy and then converted to sternotomy because for reportedly some bleeding problems and what was felt to be a fairly friable annulus. The valve implanted was a 21 millimeter Mosaic Ultra, which is a version of the Medtronic Mosaic. She suffered a postoperative stroke, prolonged debility, and then she had worsening exercise tolerance. Now, this was done at another facility, so we didn't have her immediate or intra-op echo, but noticeably in 2013, she had an echo. We did have those records that showed already she had moderate to severe aortic stenosis with a valve area of 1. And the parameters listed there, the mean gradient was 26 millimeters mercury. Now, similar to the Baptist patient, she was short. She was 5'1", and we only have her current weight. She was a bit on the heavy side, so her current BSA is 1.85. So I could only find a very old chart for the Mosaic valve, but a 21 millimeter, if she did have that BSA at the time, would have certainly put her at risk of patient prosthesis mismatch, somewhere between an effective orifice area of 0.63 to 0.72. However, she didn't really have much in the way of heart failure symptoms until July 2019. Then she had a precipitous decline in her exercise tolerance. With the New York Heart Association class 3 symptoms, and an echocardiogram showed that now she had severe bioprosthetic dysfunction. Interestingly, she also had a mild PVL. Her peak velocity was 4, mean gradient was 35, DVI I think was 0.21. Her SCS risk for reduced TAVR was 3.42%, but of course that's not accounting for frailty. And in her case, we felt that her frailty was real, that she had it as a consequence of the stroke. She had been using a walker since then. So we discussed with her redo AVR versus valve-in-valve TAVR, and given her prior experience, her frailty, and then also our concerns about this report of a friable annulus, the heart team and the patient decided on valve-in-valve TAVR. This is just a quick shot of her echo at the time of evaluation. So just quickly to go through how we think about valve-in-valve TAVR and bioprosthetic valve fracture here at UT Health. All these patients we put under general anesthesia. We are primarily a minimalist TAVR program, but for these patients, we feel it's important because there will be prolonged pacing runs and the potential complication profile of this procedure. We use the valve-in-valve app heavily. We, of course, look at the CT scan, but we use the valve-in-valve app, which we found very useful because the label surgical sizes really vary from product to product. And so what we are interested in is a true internal diameter, and the valve-in-valve app is very nicely also tells you the different sizes for each of the different TAVR valves that will fit in within the surgical valves. I think Dr. Cohen and Dr. Almamani referenced this, but the true internal diameter by bench testing that Keith Allen performed shows that when you fracture the surgical valve, it will expand 3 to 4 millimeters. And of course, it's important to know which valves are fracturable. The Hancocks are not fracturable, and the trifectas can be remodeled but not fractured. And then the last thing to consider is the valve positioning. When we fracture surgical valves, just as with balloon dilation, a TAVR valve will rise up a little bit. So we need to plan ahead of that for coronary obstruction risk. Because we were selecting the self-expanding valve, we wanted to pay attention to the waist diameter to choose our balloon size. And so for a 23 millimeter self-expanding valve, the waist diameter is 20 millimeters. So we really don't want to go above 21 to 22 on the balloon. And also paying attention to the LVOT and STJ dimensions. I'll just skip that. And so these are some of her preoperative CAT scan analysis images. The stenotubular junctions were nice between 30 and 34. LVOT averaged at 22.9. And then femoral access was fine. So I will attempt to play this film, but essentially what we did was we deployed the 23 millimeter Evolute and measure the gradient post-deployment. And so our general practice is to fracture the valve post-deployment. There are pros and cons for each, but I think most centers have moved to post-deployment a valve fracture to avoid the risk of acute AI. Also, so you can measure the hemodynamics. So you can see here that valve is nicely expanding. We used a 21 millimeter true balloon and got a post gradient of 7 to, I think that's just a typo, it should be 7 millimeters mercury. I'll just play here at the end again. You can watch the conformation of the valve and the shape of it as it comes out, especially here, you can see right there.
What size was the surgical valve? Was it 21 mosaic?
Yes,
Okay.
21.
Great.
So her post-op day 1 echo showed that the valve was well seated and functioning nicely. The peak velocity was 2.7, a mean gradient of 17. And I don't know if people see this. We often get much higher gradients, even when they're on just conscious sedation. No PVL. So interestingly, we did not, and I'd like to hear what other people think about this. We counseled her pretty heavily that this PVL that she had was not expected to change with TAVR, but it actually did disappear. She was discharged home on DAPT, very important. We send all our valve and valve patients home on DAPT. And then Dr. Almamani just saw her in clinic a couple weeks ago. Her symptoms had improved to New York Heart Association class 1 and 2. Her peak velocity and mean gradients are actually down from that initial post-TAVR echo. Still no PVL, and she's doing very well.
That's a nice result. That's
really good. Regarding the PVL, so I think one of the things to take from that is that we always tell them that it's not going to fix it, but when it does, it just makes us look better. So I would have taken that as a win. Absolutely. One quick question, and this is actually for the rest of the group, is because I saw this at a conference here not too long ago. Where do you take your gradients on these post valve and valves? Do you put it right underneath the TAVR valve, or do you stick it up into the LV? How do you measure your gradients for these patients?
Where do you put, where do you put the pigtail that you're, or whatever catheters in the ventricle?
Yeah.
It shouldn't really matter unless you have an LVOT gradient. Again, it should be all you're measuring is what is the intraventricular pressure. So, unless you have some gradient across the outflow tract, I don't think it would make a difference. Have you seen it? Have you tried and seen that it makes a difference?
It's fun. So we did one today, and significant LVH, almost cavity obliteration, and with the pigtail sitting deep in the LV, there was probably about a 12 to 13 millimeter gradient, and I thought I was going to have to frack it. I pulled the pigtail right underneath the valve, and it was a 2 millimeter gradient.
So so you had some degree of an LVOT gradient.
Right, which is, and I guess one of the things to point out when you're doing these is that you have to make sure where you're measuring your hemodynamics, because you're about to expose this person to a higher risk, procedure with a fracking potentially. And so the all importance of knowing where you're at is significant with these patients. It was just a point that I thought was
that's a good, it's a good point. And it also points out the advantage of doing the post TAVR bioprosthetic valve fracture as opposed to the pre-TAVR one, is you get to evaluate whether you need to or not by the hemodynamics, which I think is a nice advantage of that. And as you said, it's not a completely, when we first started doing it, we were scared to death. Then after we did it for a while, then we were super confident and thought we'd never get any complications. And then we saw some complications, and so then we were kind of hit the happy medium, because it is, we've published that, you can get, coronary obstruction, you can rupture the annulus if you're not careful. You can certainly tear the leaflet of the TAVR valve. So all those things are, it can happen. So it isn't to be taken lightly. I think that's a good, important point.
I just wanted to add that, it depends on what are you measuring the gradient with, because you also want to pay attention that some of those pigtails, they have side holes up on the shaft. So you don't want to pull it too close to the valve, and then the pressure gradient would be contaminated with some aortic pressures. Right. I would say mid cavity is probably reasonable. I frequently open one pigtail, which is the one in the sinus, and I use a JR4 to get the stiff wire in and go back with an in-hole catheter, put it somewhere mid cavity or maybe right below the valve. But this way you guarantee it's not contaminated with any aortic pressure.
No, that's a very good point with the, again, you have to have ideally you have a single end-hole catheter is what you want to measure the pressure through. That's a great a point for that.
Listen.
And, I think it's, let me ask our surgical colleagues, since we have two on the line here. So are you being, are you now, as we've started to see, obviously, the surgical effects of patient prosthesis mismatch are, have been well documented for a while. And so, it's a quality metric for surgeons. We've seen from the original high risk and intermediate risk trials that the TAVR valves have, tended to have lower gradients than the surgical valves, although that in the PARTNER 3A trial flipped because the surgeons were doing, putting in bigger valves. The Medtronic trial, still the core valve had lower gradients. Are you guys doing different? Are you doing aortic valve replacement differently in the last 5 years than you were before to try to, take advantage of some of these lessons that we've learned, Dr. Pollard, Dr. Hui?
Yes, I think our threshold for valve enlargement or even root replacement is much lower. It's like I said, the labeled valve sizes, I think, if you really think about the true ID, I think we're sometimes misled by the number on the labeled sizes. And I'd be interested to see what Dr. Pollard has to say. A root enlarged or root replacement is very different than a root enlargement. And I haven't had enough experience of placing TAVRs in someone who's had an enlarged root versus a replaced root. So my sense is a root replacement is probably a better setup for TAVR in the future. Dr. Pollard, do you have any thoughts on that?
Well, I know definitely as my career has gone along, we just become more and more aware of the problem with patient prosthetic mismatch. And I've always had a pretty low threshold to do something, either enlarge the root or more commonly, I've replaced the root. Usually when you enlarge the root, as you know, generally only get one more size. And so I've had, at least in my career, more success with root replacement. As far as which, and I think that probably even serves as a, with the index operation there, I think you probably even have a bigger area to place the TAVR valve if and when that becomes necessary. Because usually when we're doing a root, we're usually using the freestyle valve or something that I think can serve as a pretty good scaffold for a future TAVR valve.
Yeah, I think the other thing about root enlargement is typically after a root enlargement, the sinuses are gone, right? I mean, you just have this totally effaced sinus, and the ability to do it, the TAVR valve and valve, those are the highest risk cases for coronary occlusion that you see, because the coronaries are inevitably low and there's no sinus, and so it's a it's a setup for, then you really need that snorkel, or you need to do a basilica or something like that, to make sure that you're not going to occlude the coronary. Are you guys using CTs for to evaluate your surgical patients? Is that something that you're doing routinely now, Dr. Pollard, Dr. Hui?
It definitely is. I mean, early in my career, again, it wasn't a part of our patient workup. Now it's pretty much routine part of the workup.
So do you size off the CT, or do you still use the sizers in the OR?
I still do both, but you always like to go to the OR with a pretty good idea of what you're going to face and what you're going to have to do. Believe me, I will admit this in front of my cardiology colleagues. TAVR has made me a better valve surgeon, really.
That's good. That's
some of the lessons that you learn from that.
TAVR has not made me a better surgeon.
Well, it's interesting. It's CT thing, like the valve clinic model, when everybody comes with a sensitive evaluation and all severe AS patients get CT. Even if they go to surgery, I think it's very helpful. I can't tell you how many renal cancers and other things we found on those CTs, and when we send the patient to the appropriate, treatment. But I think it's helpful not just for planning for both procedures, but for so many other things.
No, obviously you get a great view of the calcium in the aorta, and you can, sometimes you find porcelain aortas that way that you might not have otherwise noticed. So I think that's great. I suspect we're out of time.
We're getting real close, and I'm going to open up for questions. So if you have questions, the easiest way to do this is in your chat box. Go ahead and type the questions. I'll repeat them to the people who are online. And we're going to try to shut this off here in about another 5-10 minutes. So
do you have while we're waiting for audience questions, I had a question about the coronary obstruction question. I was at SIF in Arizona, and they presented a live case where it was a valve and valve. And there was some concern about the risk of coronary obstruction. And angiographically, it looked fine, but they elected to use IVUS just to verify. And the IVUS did show that there was some pinching at the ostium. And so we've not really used IVUS much. I was just curious, what's your threshold for using IVUS or?
So let me just make sure I understand this. So they did not protect the coronary, and then they went in with an IVUS, or they had the coronary protected. They took the stent out and did it.
They had it protected from the beginning.
But how did they run the IVUS?
I think they just had a guide liner down. They did not have. I can't remember if they had the stent in or they exchanged.
They must have exchanged it. It must have. I mean,
Yeah, had exchange.
Yeah, you couldn't. I mean, unless
I'm guessing they probably did not see anything angiographically, and they took the stent out, and then just probably went in with an IVUS, and then the IVUS showed a problem.
Yeah, I think that. I mean, so it's. I mean, I haven't done it. I mean, there absolutely are cases, and this is reported, and and I've seen cases of this where, let's say you do like the first case that we saw where you have the stent parked in the LAD. And then you do an angiogram with the guide in, and everything looks okay. But the guide is actually stenting open the coronary. The guide is pushing the leaflet out of the way, and so it really is important before you really commit to pulling that snorkel stent out, that you've taken an angiogram with the guide not engaged, at least, because I think because you can really get fooled if the guide is engaged then. So
yeah.
I would be careful.
Our practice is at that time to actually do a root shot with the pigtail coming from the radial and see if the coronaries are filling.
Yeah, I mean, anything but just don't trust the angiogram done with the guide in the coronary. I think that's the key.
And one other lesson I've learned from my own experience is, like Dr. Alvarez mentioned earlier, using valvuloplasty to suggest if the coronaries are filling or not. My lesson is have the pigtail in the non-coronary cusp or above, not in a right or left, and inject and be falsely assured that the coronary is actually getting filled.
Yeah, no, you can, that'll fool you. You need to have it above the STJ.
Exactly.
We had
So we did the mistake of having it in right coronary cusp and injected and did the BAV. Everything was filling nicely, and then the RCA got shut down.
We had an interesting case of delayed coronary obstruction, and patient, like the night of the procedure, started having chest pain, and that demonstrates, in the case, I did something that demonstrated what Dr. Cohen is talking about. I engaged through the valve frame, was a core valve, and then put a guide liner in a vessel, and I injected through the guide liner, and I started pulling my guide liner back, and the minutes behind the leaflet stood up in front of the core. And it's saved in the angio, and it's nice. So that's, if you take the picture with the guide, it's just pushing the leaflet away, and then you pull the guide out and it may stand up. So it might be a case like this. I assume IVUS might have been helpful, but we wouldn't think.
I think the thing we learned the very, very hard way is that, the reason why we do the snorkeling the way that we do with the stent, prophylactically in the LAD is because sometimes if you get a coronary obstruction or even a partial coronary obstruction, delivering the stent from the guide into the coronary can be super hard because you're pushing against the top of the surgical valve, or just the native valve. It can be, really hard to do that. And so it's much easier to pull it back than to advance it. That's for sure.
We have one question that's been sent to the panelists. I think you guys can see this about the line of death. They say leaflets obstructing left main ostium. The root shot in the live case show white line, and leaflet obstructing left main. Can you guys address that, please?
So the live case, I guess they're talking about the SIF meeting that Dr. Hui was at.
That's right. That's, yeah.
Do you have a comment on this, or do you?
No, I mean, that is what happened.
Okay.
I guess I had not seen people using IVUS before.
Yeah, I mean, so the white line is
things like that.
I mean, the line that they're referring to is the valve leaflet itself.
Yes.
On basically catching it in cross section on the aortogram that you can see. It's something, again, that is often a concern that it's going to occlude, or that it is, later that night or something like that. So people look for that, and that, again, that would make me go back and look very closely. Even if the flow is normal, if you see that, that line, you want to look, super carefully to make sure, you're not gonna have a problem 5 seconds after you pull the wire out of the coronary.
So, Dr. Cohen, going in the same line, so what are the things that make you go towards Basilica to start the case with? When do you think of Basilica here?
I think you think of it, especially if if you have a very bulky leaflet. I think, these days, Basilica is a pretty safe procedure. Again, not everybody knows how to do it. Not everybody has done one from it. But once you've done a couple of them, it's complicated. There's a number of steps, but it's a pretty safe procedure and really can prevent, the guys who are really experts in it, if you talk to Adam Greenbaum or, the guys at Emory, you don't need to protect the coronary, because protecting the coronary, putting in a snorkel stent is a good short-term solution. It's a good bailout. It's a good way to, save yourself a problem. But people, I think there are legitimate worries about the long-term outcomes of a snorkel stent. So if you want to have a good long-term outcome with valve-in-valve and it's high risk for coronary occlusion, I would definitely make an effort to do a Basilica if you can. With that, if you don't have experience with it, get a proctor to come and walk you through it. I think, Ahmed, you've done a few of those, haven't you now?
We've done Basilica, yes, and it's the things that we.
Hey, Ahmed, real quick, just to kind of point out, because I think there's some non-TAVR people on the thing.
Basilica?
So
Okay.
Basilica actually is a way to transect the leaflet so that you have more room and it doesn't obscure the thing. So anyway, keep on, because I'm pretty sure there were some people
Yeah.
who didn't know what Basilica was.
Like Dr. Alvarez has outlined, where we're talking about risk of coronary obstruction. So when we think the surgical valve leaflets, when they are open by the TAVR frame, are very close to the coronaries and may lead to obstruction or impedance of the flow, then we think about Basilica. So it's the same thing. We look, I look at the most important thing is the virtual valve to coronary distance, and take into consideration if you want to do valve fracture or not. So, if it's like 4, you might be okay if you don't want to do valve fracture. But if you want to do a valve fracture, or you may need it, then I'll start getting anxious, because there's no real data about what's a safe VTC, or virtual valve to coronary distance. And the other thing is the sinuses, how big are the sinuses, and how high is the STJ? And if that coronary is above the frame, then of course you're safe. So if it's a low coronary, short VTC, or virtual valve to coronary distance, and narrow sinus or short STJ, where there's risk of sinus sequestration, then I will definitely think about Basilica. Now, Basilica is much easier done on the left side than the right side. There's some data suggesting if the patient needs both Basilica, then outcomes have not been great. So people are, if both coronaries are at risk, they're tending to do Basilica on the left and just a snorkel stent on the right side. But again, it's just looking at that CT. The pre-planning CT is the key for all those kind of procedures. Now the problem comes in the smaller, TAVR programs, when a lot of times, the operator's just starting to do TAVR, they don't have that experience to look in the CT, and then they may get in trouble if that company on the analysis doesn't alert them about this. And I've seen one example that was pretty scary. Very close coronary, and if they've done it, then they definitely include that coronary. So, but CT, and look at it. Both Edwards and Medtronic, they have advanced imaging departments, and you can ask them specifically to give you those virtual valve to coronary distance. Ask them about Basilica in this case if it's needed, and they can provide you with a lot of insight.
Yeah, I think they just presented at the CRT meeting, results of, several hundred Basilicas in a national registry, and overall is pretty safe. There are proctors around, more and more proctors are available because more and more people have done it. And it is really it's a very clever technique. Now there's balloon assisted Basilica, right? Where you, after you've lacerated the valve base with the wire, you actually balloon the base to expand, make it even a bigger expansion before you lacerate the whole valve. So I think it's evolving, and it's a good technique as you get to sort of more, it's in the more advanced range, but it's something which I think, most decent sized programs are going to want to have in their armamentarium in the future. It's a good technique. Anything else, or are we kind of out of time? I know we've gone very long.
Thank you very much, Dr. Cohen. We appreciate you coming
No,
down.
it's a pleasure to be here. It's great to see, to see a lot of live human faces. It's great to see our old fellow, Dr. Alamani, doing such great work in San Antonio and tweeting about it prolifically. We, we see all of that. And I hope I'll get to come to San Antonio sometime for real and get that steak that Dr. Alamani owes me.
Absolutely. You have the final comments. We're going to close the meeting now due to time. Again, thank you so much on short notice to do this for us. I think everybody learned a lot, and these meetings have been something that's really advanced cardiology care in San Antonio. So any final comments, sir?
No, it's just, again, it's a pleasure. It's, again, all these cases were very, they're well selected and instructive in their own right. And I think, we all tend to think, TAVR is a, pretty straightforward procedure, and most of the time it is, except when it's not. And I think that's, the lesson is you need to be prepared. I think, as Dr. Alvarez said, prepare for the worst and hope for the best is always the best attitude. And I think, having the more you see, there's lots and lots of, people out there who have lots and lots of experience. So if you don't have enough experience, call your neighbor, call your friend, call your colleagues across the country. Take advantage of everybody who's out there.
Again, thank you so much. You'll be hearing from us.
Okay.
Again, everybody have a good night. Thanks for joining.
Have a great night.
Thank you.
Take care.